oculomotor nerve together with trochlear and abducens. All right. Why? Because the three of them are involved in handling the extraocular muscles of the eyes. And their symptoms are similar. So you see a patient, you want to know why. For those who are just joining the live stream, this is Dr. George, and this is PLAB-1 classroom hosted by Air Clinic. Okay, so we've talked about optic nerve. Today we are going to discuss oculomotor nerve, and we're going to be discussing it together with trochlear nerve and abducens. So nerve 3, 4, and 6, they go together because they are all involved in the supply to extraocular muscles. Okay, so oculomotor nerve it basically supplies all extraocular muscles. Additionally, it supplies muscles around the eyes, okay, and is involved in light reflexes, the motor aspect of light reflex. The sensory aspect of light reflex is carried by the optic nerve. The optic nerve is essentially sensory. So eventually there is a pathway where known as the Eddington-Westphal nucleus found in the midbrain that links that sensory pathway from the optic nerve to the motor pathway, that Eddington-Westphal nucleus is actually the nucleus of third nerve, the nucleus of motor nerve. All right. So from there, impulses now flow to the eye. So it means oculomotor nerve, apart from controlling the extraocular muscles, also controls the pupils. Okay. So whenever a pupil contracts, contracts, okay, it's controlled by the oculomotor nerve. All right. So now damage to this nerve will cause diplopia in different directions. There's also dilated pupil, like we mentioned, and complete ptosis. Okay, so it's one of the nerves that controls the eyelids. Okay, so when oculomotor is damaged, like I mentioned, it handles pupillary constriction, because oculomotor by itself will cause pupillary constriction, as we have talked about in light reflexes. So when there's a damage to the oculomotor nerve, there will be pupillary dilatation. Okay, it should just be dilated. Okay, and then there will be ptosis, and of course there will be diplopia. So on looking up means third nerve palsy, but it can cause diplopia in other directions. Like it can cause diplopia in multiple directions. So now there's this thing about the extraocular muscles. There's superior rectus, inferior rectus, medial rectus. Okay, and other extraocular muscles like lateral rectus and rear oblique. All those ones are supplied by the other two muscles, the other two nerves. Okay, that we are going to mention very soon. So a patient that has oculomotor palsy will have eye that deviates downwards and outwards. Okay. Now they put to the side where the muscles are still intact. So it's just like during facial nerve palsy. All right, the face will deviate to the good side. Why? Because on the good side, the muscles are still intact. So you now have unopposed action of the facial muscles. All right, pulling the face to one side. Why the side that normal side? Motor action of the muscles, the ones that are normal, therefore pulling the eyes downwards and outwards. Okay. down muscles written here are the ones that control motor, right? Now, trochlear nerve is the fourth nerve. So trochlear nerve is the one that supplies. There's LR6, SO4, then A3. All right, that's the formula. Good evening, Noya. You're welcome to the class. There are some persons that I'm just seeing for the first time throughout this year. Is that true? I think I'm seeing people like Bishop for the first time this year. Okay, so laryngeal sulfate, okay, LR6, SO4, A3. Okay, so now trochlear nerve will handle superior oblique, SO4. Okay, so the fourth nerve will handle the superior oblique. And what does the superior oblique do? Because it is superior and oblique, it will put the eyes downwards and inwards, kind of the opposite in the opposite direction. Unlike all these lateral rectus, superior rectus, inferior rectus, they just pull it in the direction that they are named. So superior rectus will pull the eye to the superior, that's upwards. Inferior rectus will pull the eye downwards. Lateral rectus will pull the eye sideways, that's laterally. Then medial rectus will pull the eye medially. But inferior oblique will pull the eyes upwards and outwards, upward and downwards. Okay, upward and what am I saying? What am I saying? It will pull the eyes inferior oblique. It will pull the eyes in and out or down and out. Okay, so now superior goes to pull the eyes down and in. It's a palsy of the superior oblique. The patient cannot look down and in. That's what it means. The patient cannot look down and in. So in situations where a patient needs to look down and in, like climbing staircase, okay, the patient is going to have a problem with climbing the staircase because when you're climbing, you have to look down and in. Okay, so walking down the stairs or reading. So both but dilated pupils will mean third nerve palsy, of course. So fourth nerve will not affect the pupils because, like I told you, it's not involved in pupillary reflex. It's the third nerve that is involved in pupillary reflex. So all you just expect is that then will give you a history that when he's going down the staircase, when you are going down the staircase, you have to look down and you have to look inwards. So going down the staircase. So and also when he's trying to read, and also when you are reading, you have to look like you don't hold your book up, you hold it down. So you are going to look down and in, trying to focus on the book. You're going to look down and in. So you have double vision. And that's the major thing. Diplopia, when you are trying to make that motion within the range of the affected muscle. So that's what you get. Now, nerve 6. Six is the abducent nerve. It innervates the lateral rectus. And like I mentioned earlier, LR will just pull the eyes laterally. Okay, so if there's an issue with the trochlea, it means the eye cannot go laterally. And in what situations do you have to look sideways? Just think about all these possible situations where you have to look sideways. You'll be having an issue. And also, like when the person is going on the road, the person will be bumping into people, just bumping into people on their affected on the peripheral of the affected side to turn their whole head to be able to have it. So diplopia on looking sideways. Dilated pupils will indicate third nerve palsy, like we mentioned, of course. Okay, so without explanation, I think we are done with those three nerves. Now we'll go into trigeminal nerve. Now, trigeminal nerve is essentially sensory. Okay, essentially sensory. Because why is it called? Yesterday I explained why each of the nerves are called what they are called. Okay, so like trigeminal nerve is called trigeminal because it has three major branches. Trigeminal, three branches. All right. So we call them the V1, the V2, and V3. Okay, so V1 is ophthalmic nerve, supplies the upper part of the face, right? Beside from the angle of the eyes, the lateral angle of the eyes, upwards. So all those forehead side, all those sides, the lateral side of the eyes and all those things are supplied by the ophthalmic sensory nerve. So if you cannot feel on that side of the face, it means the ophthalmic nerve from nerve 5 from is affected. Now, nerve 2 is between the angle of the eyes and the angle of the mouth. Okay, so it's called the maxillary nerve, maxillary branch. Okay, so it supplies, caters for areas, sensation around that area. Okay, so between that angle of the eyes and the angle of the mouth, that's where you refer to as nerve V2. Okay, second branch of the trigeminal nerve. Then nerve V3 is below that angle of the mouth. Okay, so it means the cheek is actually supplied by nerve V2, which is the maxillary, while the mandibular area supplied by nerve V3. Okay, so taking all that into consideration, also trigeminal nerve has a motor aspect, right? And the motor aspect is involved in all these muscles of mastication. And when you talk about the muscle of mastication, you're talking about temporalis muscle, masseter, all those stuff. So trigeminal nerve also controls muscles of mastication. So anytime you are chewing something, you are stopping that big meat, that chicken, all the things that you ate in this Christmas, just go and thank your trigeminal nerve for all the work it has been doing. The fact that you are enjoying, when people say you are enjoying, and when they say well done, just tell them, don't thank me, thank my trigeminal nerve. All right. So that's the muscle we are using to enjoy. So it also innervates the cornea. So corneal reflex, that's one of the things that you test when you are testing for trigeminal nerve function. So now, one thing about all these nerves is that you also have to know their pathology, because if you want to do cranial nerve examination, you have to examine the nerves, and you should know how to examine them and what to look out for. All right, so like trigeminal nerve, one of the things that you test in the sensory aspect is the size of the face, because obviously the size of the face are supplied by V1, V2, V3, right? Then also corneal reflex is also supplied by a trigeminal nerve. And corneal reflex essentially tells you that this patient is alive. So if corneal reflex is gone, it tells you that something is wrong with the brainstem. All right. So so a patient now has corneal anesthesia or loss of corneal reflex, and jaw jerk. Also, you check jaw jerk reflex too, and there will be deviation of the jaw as well when there is affectation of the trigeminal nerve. Apart from facial anesthesia and all those things and all those stuff. Now there's this condition known as trigeminal neuralgia. Okay, that's like inflammation of the trigeminal nerve. Okay, so it will now give this sensation of electric, stabbing, knife-like shooting pain on the face general, you can use anti-epileptic, gabapentin, though gabapentin and pregabalin are not directly anti-epileptic agents. They are more like neuromodulators, sort of. Okay, neurosuppressants. Okay, so we'll move to facial nerve. Facial nerve is a very, very popular nerve because anytime you talk about stroke, there's high chances that you're going to talk about the facial nerve because most times it is involved. When you even see the sixth nerve being involved, you should think of the brainstem more. But most times, facial nerve in strokes that are involving the basal ganglia, strokes that involve the cerebrum, intracerebral hemorrhage, in fact, we see a lot of facial nerve affectation of the upper motor neuron type. Okay, so when you're talking about the facial nerve, what does the facial nerve do? Of course, it has the motor component and a few sensory. Unlike trigeminal that has more of sensory and a few motor, facial nerve has more of motor and a few sensory. Okay, so the motor aspects, because it is called the facial nerve, caters to the muscle of facial expression. Okay, so anytime you are able to smile, you're able to laugh, you should. When someone says, I like this your smile," just say thank you, but actually not me you should thank. You should thank my facial nerve. Okay, so just use that one to tell them that you know your neuroanatomy very well. All right, so it caters to the muscles of facial expression, and in addition, it has the sensory supply to the anterior two-thirds of the tongue. Okay, and it has a tiny supply to the nerve that is known as nerve to the stapedius. Okay, that stapedius is one of the muscles within the inner ear that helps to stabilize the stapes. Okay, the three small tiny bones inside in the inner ear, in the middle ear. Okay, the middle media of the ear. So one of the things that stabilizes is stapedius muscle, and that muscle is supplied by nerve to stapedius, which is a branch of the facial nerve. Okay, so you want to consider that as well. Now, symptoms of facial nerve involvement. Let's use the clinicals to try to remember the symptoms. First of all, when you see a patient with facial nerve involvement, you have facial deviation to the normal. So you now say her teeth, facial deviation. All right. So apart from that, you can also ask the patient to blow a trumpet. It is with those muscles around the face that you're able to blow a trumpet or whistle. Okay. So when the patient blows and you touch the affected side, you notice that there is loss of tone on the eyes. You'll be able to notice quickly that one eye doesn't close as well as the other eye. All right. Like when you attempt to open the eye that is affected, you will notice that the eye is easily open. In fact, sometimes the eye doesn't even close at all. It's just there staring at. Someone should remind us. As when you tell the patient to close the eyes because of facial nerve affection, the affected side, the pupils, the eye cannot close essentially. Okay, so you will now be seeing the whites of the eye. What's that phenomenon called? Okay, now there is also when you tell like the muscles when you're able to wrinkle your hair on your forehead, that helps you to wrinkle your forehead. Okay, it's also supplied by the facial nerve, like we mentioned, muscles of facial expression. So it's also supplied. Like when someone wrinkles his forehead, it kind of means that they are surprised or that they are thinking about something. So that tells you that that muscle is affected. So when you tell the patient to stabilize the patient's head and tell the patient to follow your hand and you move it up, and you can see that on the affected side, that wrinkling is absent. Okay, but if it's upper motor neuron, that wrinkling will be absent. If it's lower motor neuron, the wrinkling will still be present. Okay, so there's this code that says that the upper part, which is from the angle of the eyes upwards, will not be affected. Okay, so that's how you know that there's an upper motor neuron lesion of the facial nerve. Then also you go and test the tongue. You get maybe something familiar taste, right? And you try to dip it on the anterior tutorial of the tongue. So if the patient is still able to determine the taste, of course, the eyes have to be closed so that you'll be objective, or the patient can be objective. They don't have to see what you are bringing to make them to taste. So finally, when they taste it and they're able to determine the taste of what they tasted, then you don't know it is intact. Sensation is affected, which is catered for by the facial nerve. Then also there's this phenomenon known as hyperacusis, sound of that nerve to stapedius that I mentioned earlier. So when you come from the patient's back and you attempt to rub your two fingers, right, on the side of the patient's, in front of the patient's ear, you will notice the patient will tell you that he hears the sound louder on the affected side. So it's known as hyperacusis, like you're accentuating the sound on that side. So it's known as hyperacusis. Now, there are about 7 things, and I think I've mentioned like 6. Okay, so with all this, you will be able to tell different things that the facial nerve does. All right. So, of course, failure to close the eye, loss of nasolabial folding, deviation or drooping of angle of the mouth, loss of taste in anterior tutorial of the tongue. Now, it has the upper motor neuron type and the lower motor neuron type. And upper motor neuron type usually follows stroke, tumors, and things like that. Right? Tells you that it's upper motor neuron. Then demyelinating diseases and all that. But lower motor neuron, okay, will usually there's this phenomenon known as the Bell's palsy. Okay, so that Bell's palsy is actually the cause of that lower motor neuron type. It's kind of an idiopathic facial nerve palsy. Idiopathic, you don't know the cause, but sudden onset facial nerve palsy. Usually, they attribute it to viral origin anyway, but it follows an upper airway infection, upper respiratory tract infection, and all that, or gastroenteritis. So that's that about that summary. All right, so invades the voluntary muscles of facial expression. Now, the next nerve on our list is the vestibulocochlear nerve. Okay, now, like I mentioned earlier, the name of the nerve tells you the functions or the nature or the anatomy of the nerve. Okay, so vestibulocochlear tells you that there are already 2 different nerves in one. So the vestibulocochlear nerve is like 2 in 1. So there's the vestibular branch and there's the cochlear branch. Okay, so vestibular goes to the labyrinth, okay, labyrinth and all those things that are involved in maintenance of balance within the inner ear. All right, while the cochlear nerve goes to the cochlea, obviously, okay, and the cochlea is involved in maintenance of hearing, okay, in hearing, audition. Are you talking about upper motor neuron? Yeah, trauma is part, should be part of it. Then of course, parotitis, parotid gland enlargement and parotitis should be involved in lower motor neuron because facial nerve passes through, has a very strong relationship to the parotid gland. So parotitis, mumps, there may be affectation of the facial nerve. Yeah. All right. So coming back to our vestibulocochlear nerve. So we mentioned that there are two different branches, vestibular branch and the cochlear branch. Okay, so when there's affectation of the vestibulocochlear nerve, it means you are likely going to have vertigo, nystagmus, inability to balance properly. There may even be an ataxia. So it has a very, very close resemblance to what do you call it? To cerebellar lesions, because cerebellum is also known for motor coordination and maintenance of balance. Okay, that's what the cerebellum does by way of its function. Okay, so this vestibular nerve is also involved in maintenance of balance. Now, the cochlea on its own hand is involved in audition. Okay, that cochlear nerve is working properly. So, if for whatever reason your cochlear nerve is affected, then my brother, now signs and symptoms, now you go to use the understand person. Thank you very much. So that is that about that. Now, damage will cause deafness and balance problems, like I mentioned earlier. So there will be sensory ataxia, dizziness, and vertigo. It has connection with the posterior column. All right. So what single test will you do to differentiate vestibular nerve damage from what do you call it, cerebellar damage? Is a test known as the Romberg's test. Okay, whereby you tell a patient to stand with the two legs, feet together, right? Stand still with the 2 feet together. Okay, arms spread by the side, horizontal. You instruct, first of all, you tell them to stand that way, and you watch. Then after a while, you instruct the patient to close his or her eyes. Okay, so when the patient closes the eyes, the patient will start falling, and you say that Romberg's test is positive. Okay, so in that case, it means that the lesion is sensory, the sensory ataxia. Okay, all right, which means that it's coming from the vestibulocochlear nerve, which also means that the dorsal column medial lemniscus, which is posterior column, is affected. Okay, that's when you say that the Romberg's test is positive. Now, but cerebral lesions, regardless whether the patient closes his eyes or does not close his eyes, there will still be affectation of balance. All right. Nerve 9, the name implies glosso. Whenever you hear glosso in the body, you are talking about the tongue. Glosso. So glossopharyngeal nerve supplies both the tongue and the pharynx. So the tongue and the pharynx. So remember that the anterior two-third that was supplied by facial nerve. It means we are owing the tongue another innervation because the posterior 1/3 is still remaining unsupplied until the glossopharyngeal nerve now came and supplied it. So glossopharyngeal nerve did that, paid that salary back. Okay, that loan that was taken by the facial nerve was paid back by glossopharyngeal nerve, but it didn't pay in full. It just paid the 1/3. All right. So also there will be supply to the pharynx. So you now use the uvula. You now use division of the palate and all that to note glossopharyngeal nerve damage. Okay, so when there's that's the one that supplies the uvula. That's why when there's glossopharyngeal nerve palsy, they cannot make this R sound. All right, you'll notice that there's division of the uvula. So when you tell the patient to open the mouth, okay, and make the R sound, you'll notice quickly that there is division of the uvula. And of course, if you have the strong patients to actually go and start looking and testing the posterior 1/3 of the tongue, which I suspect will be very difficult, okay, and will not be advisable in this corona period to just actually go and put your nose and face and mouth and everything inside the patient's posterior aspect of his tongue just to test the glossopharyngeal nerve. Anyway, just test for the uvular deviation and you'll be fine. Okay. Then the 10th nerve on our list is the vagus nerve. Okay, so vagus, I don't know why it's named vagus anyway, but I suspect because it's very long. Okay, so it's like a vagabond. It goes very far. It just keeps going, just keeps going. So it's actually the nerve that innervates most of the visceral organs we are talking about, from the intestines. So it travels. Imagine something that is coming from the brain all the way from the medulla. Remember that the cranial nerves have different origins. Okay, like the main brain, which is the cerebrum, gives rise to the optic nerve. The first two nerves, okay, olfactory and optic nerve, come from the cerebrum. Then the midbrain will give rise to the next two, which is the third nerve and the fourth nerve. Okay, then 5, 6, 7, 8 will come from the pons. Okay, why 9, 10, 11, 12 come from the medulla oblongata. All right, so imagine all the way from the medulla oblongata, the vagus nerve became a vagabond that started traveling around the entire country of the body, all the way down, even your anus sphincter, to supply every visceral organs to touch all of the vagabond. So the parasympathetic supply, and you know that these nerves have okay, yeah, but don't be a vagabond anyway. When you get to the UK, don't be a vagabond. Focus. All right. So this vagus nerve actually carries the parasympathetic nerve. So I remember that parasympathetic nerve is what controls a lot of all these visceral organs. Parasympathetic is majorly the control. So when there's increased parasympathetic nerve supply, there will be constriction, just like the intestines, intestinal motion, bowel movements, gastric emptying, all those things are supplied, are controlled by the parasympathetic nerve, which is carried by the vagus nerve. So the vagabond still has some functions to do in the world of the body. All right. The next nerve on our list is the accessory nerve. Okay. Accessory nerve, I don't know why. Okay, why is it called accessory nerve? All right. It supplies the accessory muscles of the body, accessory muscles of respiration. Okay. Muscles that assist the shoulder movements. Okay. Like trapezius. Okay. So in the absence of accessory nerve, this your sternocleidomastoid will be affected as well. And sternocleidomastoid is one of the very, very important muscles that you use for turning your neck. So if sternocleidomastoid is affected, imagine how you will now have this torticollis. So you cannot turn your neck to the other side. That's very, very, very distressing and discomforting. Okay. So, and also the person cannot shrug. So let's say you get to a station, you know this shrugging. Shrugging is like swag. So someone is just telling you one thing that you don't really like. You just be like, just shrug. Okay. So imagine that you cannot shrug. So there will be no swag again. So when your accessory nerve is affected, you don't have access to swags anymore. All right. So the last nerve on our list, and I hear that there's a new cranial nerve somewhere. Can't remember the name, but the last one on this list is the hypoglossal nerve. Okay, anything that we mentioned glossopharyngeal, we mentioned facial nerve, but they are all sensations of the tongue. You know, the tongue has this map that just divides the tongue, those sour taste, sweet taste, salty taste, you know, all those stuff. They are all sensations of taste. Okay, but the actual muscle that moves the tongue is supplied by the hypoglossal nerve. And remember that the tongue itself is actually a muscle, because if the tongue is not moving, you cannot vocalize, you cannot articulate speech. For you to be able to talk, your tongue, your mouth, your palate, your uvula, everything, they all work together for you to be able to produce sounds the way you want it to be. All right. So hypoglossal nerve, when it's affected, there will now be deviation to the same side as the lesion. That's the only one that causes that. Because in uvular deviation that is found in muscle-pharyngeal nerve, it should be deviated to the affected side. In facial nerve deviation that is found in cranial nerve 7 palsy, it should be deviated to the normal side. Okay, but in hypoglossal nerve palsy, it will be deviated to the affected side. All right. So, and the reason is that hypoglossal nerve on the right actually cross to supply the muscles on the other side. So there's how it is anyway. If you want, if you are very, very curious, you can go and browse it up or check up the anatomy, the microanatomy that is involved. But there's how it crosses, and that's why it is affecting that same side. So on that note, I think we have done justice to the cranial nerves. Do you have any questions concerning the cranial nerves? How do you test the cranial nerve 12? Just basically just stick out your tongue. Okay, stick out your tongue, and there'll be muzzle wasting now. There'll be muzzle wasting, tongue wasting this time around. So there'll be fasciculations as well. You know the meaning of fascicular? It should just be vibrating, like tiny spasms, fasciculations of the muscle, just like you see in lower motor neuron lesions. So that's what tells you. So something that is the direct opposite of this is the beefy red tongue that is associated with vitamin B12 deficiency. Okay, or like you see in children, children that have what's the name of this syndrome again? Hi, person will get this one. I don't say it's not just pediatric. What's the name of this syndrome? This type of vasculitis is found in children. They have this cherry tongue. Okay, so any questions concerning the cranial nerves? Dr. Bishop, Dr. Noya, and Dr. Shara. Any questions? I'm getting ready to call it a night. Please, what happens to tongue in upper motor neuron lesion? My brother, it will not be different from lower motor neuron lesion. You know that cranial nerves, things that affect the cranial nerves, hypertrophy. No. It wasn't talk say when they check the tongue check. Anyway, the thing is, that's how it is anyway. It seems most of the cranial nerves, where they tend to be affected is in the lower motor. Most of them. It's just things like facial nerve that actually have both upper motor and lower motor neuron. Okay, most of them is in the lower motor that they are affected. I don't know how you differentiate upper motor neuron of hypoglossal nerve from the lower motor neuron. I don't think anybody will ask you that, but it's a nice question. Help us find out the answer and tell us in the next class. Thank you very much, Noya. Any other question? Yeah, check it up. In the absence of questions, just quickly introduce what we are going to do the next time. We're going to be treating meningitis. Okay? We're going to be treating meningitis, the organisms involved and all that, symptoms, treatment, of course, and the management of meningitis. Okay? So key points, signs of raised intracranial pressure, lumbar puncture, and all that, and all that, and all that. You know, when you do lumbar puncture, there are some things you expect to find. All right, so do read up and prepare for the next class. I'll see you guys tomorrow. Continue where we stopped. Okay. Thank you for attending class. And I believe it was of great benefit to you. Thank you very much.